The PALOMA-3 study, as everybody knows, is a randomized study comparing palbociclib with fulvestrant and fulvestrant placebo in patients that progressed on endocrine therapy, and also heavily pretreated population. This study showed very early on efficacy results for the primary endpoint. There was the progression-free survival, already presented and published in the New England Journal of Medicine 2015. We are continuing to follow this patient for quality of life, safety, and of course the overall survival secondary endpoint. So today we presented data on the overall survival, and this is also the first time that a CDK4/6 inhibitor in a phase 3 studies is reporting overall survival data. So the results show that in the 521 patients randomized 2-to-1 to 2 treatments, the patient that received the combination with palbociclib have an improvement in overall survival up to 6.9 months, and this is maintaining the same improvement that was seen in the progression-free survival. With regard to one of the stratification factors, particularly looking at endocrine sensitivity, patients have responded to prior endocrine therapy in the metastatic setting or did not progress in the first 2 years of endocrine therapy in the adjuvant setting. This group of patients, that was the largest, by the way, of the 521, more than 400 patients, had a different overall survival, an improved overall survival at 10 months. So the importance in the setting of metastatic breast cancer, particularly hormone receptor positive, is relevant. First of all, triple negative breast cancer patients progress very quickly, have a shorter survival, and not many treatment options. Hormone receptor positive metastatic breast cancer have many more options in treatment. That's why it's been always difficult to prove overall survival advantage, particularly in the first line setting. These patients were heavily pretreated before and after they received the investigational treatment. But relevant to this is the data we were presented with regard to the fact that patients that received the treatment, the investigational treatment with palbociclib, stay on the study for longer time, had to wait much longer before going to chemotherapy. And so overall, this had an impact not only on quality of life, as already mentioned, also clearly contribute to the improvement in overall survival that we see. And I think this is relevant because it's also important to see, compared to other studies that have been presented, that this benefit that you gain early on with the treatment moves all the way to the end. There is not single treatment that will completely change the outcome of this patient, but there's an incremental contribution from various treatments. So having this treatment for patients at this time of their disease, as the study investigation was, I think is very relevant.
Well, taking these results forwards, is there anyone with HR-positive advanced breast cancer who you would not recommend palbociclib for?
I think for the study patients, the patient progress on endocrine therapy, there is no patient for which we would not recommend. And the reason being that if you look at the overall survival for the control group, if the patient had, in the general population, was between 27.5 to 28 months. But when you start to define the different subset, clinical subset, it was less than 4 months for the visceral metastasis. So we know why endocrine therapy is indicated for patients with hormone receptor positive disease. You do not want to go with endocrine therapy single agent in visceral metastasis patient because it would be ineffective. And the magnitude of benefit is seen also in bone disease and non-visceral. So I don't see any group of patients that will not benefit from the combination of this drug or palbociclib.
And then I guess all the approvals and availability and access needs to be in place for this to be standard of care.
Absolutely. I think in the US we are fortunate that the drug has been approved and is available to patients. It's been already 3 years, particularly with the extension to the combination with fulvestrant. Clearly there are other countries and other realities that have to deal with the approval process. But just to go back to the endocrine resistance, PALOMA-3 was very significant, also allowing us to study the biomarker associated with endocrine resistance. And we reported that, in fact, the patient that had the most common mutation associated with endocrine resistance not only benefit from the treatment combination, but also probably do better. So if you have a 35% chance to have an estrogen receptor mutation or 30% of PI3 kinase mutation, I think you know that, particularly in the advanced setting, you cannot give a single agent. You must give a combination with palbociclib.
And finally, if I could just ask for your thoughts and your experience with what CDK inhibitors and CDK therapy is doing to change the breast cancer space.
Yes, so I've been using these agents in the advanced setting for several years because I'm fortunate enough to have the FDA approval. I can see the patient do very well. The safety profile of palbociclib is incredible compared also the others as well as the chemotherapy, of course. There is minimal neutropenia, never associated with the increased risk of infections. This neutropenia is very well managed with dose reduction or dose delay. Usually happens in the first few months, and then patients do well and just need to go back to patient office once a month. So very well tolerated. Patients have been treated for a long time and they respond. I have patients who have been more than 2 years on the treatment, and they are responding and very stable.
Very so. Do you think that any emerging new generations of CDKs are going to improve on the results that we've seen, or is it making the best of a good situation?
I think it's very difficult to have the new agent, new CDK4/6, they have the same safety profile, the same efficacy. Of course, it's nice to have a first-in-class, and there will be other agents that will come. Of course, we are hoping that this agent will be successful also in the adjuvant setting, where certainly there is a need for better endocrine therapy to prevent resistance. Certainly we know that there is investigation ongoing with HER2 targeted therapies for the triple positive tumors. So there will be other applications for this class of agents once we have established that these are safe and effective. And in the future, of course, combination with some other agent, maybe even the sequence with some agent, if we learn a little bit more why some patients progress, how they're going to be preventing the progression.